This conference will now be recorded.
This is the high-risk recurrent advanced prostate cancer group for the 16th of March, Monday night, and we've already got a fairly large crew of people here, which is great. I'm happy to see everybody. But within ANCAN, we've actually been having some discussions, and the reason we've been having these discussions is because all of a sudden people are realizing the strength of these virtual meetings, and they are pretty powerful, I have to say. And we realized this a long time ago. That's what the blog piece on the ANCAN blog is related to, and you can read. And so we had to decide, well, do we want to put ourselves right out in the forefront to the extent we can, go out and seek publicity and let people know what we're doing? Or do we just sort of want to amble on as we have been and be opportunistic? If something arises, take advantage of it. The problem with putting our name out there is twofold. The first is that we don't have the capacity. If we had 5 people come in and say, well, we'd like to add a group, I don't know that we could do it, just because of the work behind the scenes that it takes to get a group up and running. And just this past week, we've added 2 new groups to our offerings. If you go to our website, you'll see them there, and we'll be sending that out in a blog, in a email blast this week. And the other thing is, the groups are already well subscribed, or a lot of them are. So, you know, when you consistently, our experience has been, when you consistently get to more than 20 people in a group, it's not a great experience for the group members. And so what we generally do is we split and we add another group, which is what we've just done for our active surveillance prostate cancer group. The problem is with this group, this particular group that we're in right now, we don't have any play. We can't split anymore. We're running a group a week, and we ain't going to be running 2 groups a week. That's for sure. So where do we go from here? And so to some extent, we're a victim of our own success. Anyway, that's just a little bit of background as to what we're thinking right here about the social distancing and the pandemonium that the pandemic is causing. We like these pan words, by the way. Pandemonium, pandemic, pan-cancer. Pan-cancer is a good one. As most of you know, we run some pan-cancer groups. Jake, somehow or other, what's that, pancakes?
I like pancakes.
Yeah. Jake, we lost the names of Jim Ward and Dennis McGuire. I have no idea why. Could you reinsert them?
Are you still there, Jim Ward?
Yes, I am.
Okay. Yeah, I don't know what happened. I named them.
I don't know either. All right. Well, I don't think we have anybody new. So I am going to go down the list of everybody that I have, and let's see who would like some time to talk about their situations today. I do want to say to everybody who's on this call and anybody who's listening that we sincerely extend our condolences to Jim Ward, who lost his dad a couple of weeks ago, or a week ago. I think his dad was 91. Jim will tell us a little bit, I hope. But it is always a difficult situation to go through the loss of a parent. And you've been in our hearts. We've been thinking about you, Jim, and I'm sure everybody extends much comfort to you.
Yeah, well, thank you, Rick. I appreciate it. And yeah, I'd be happy to share just a little note about him.
Okay.
You know, yeah.
Excellent. Well, so you get a tick by your name, so I know we have to stop by you. Okay, let's start with Ken Anderson. Ken, anything you'd like to speak about tonight?
No, at the moment I'm good. I'm just waiting for Paul to put the order in for the PET scan, so I'm good.
Okay. Jerry, anything that you'd like to, Jerry Deans, anything you'd like to talk about tonight?
Well, I could just take just a few minutes to kind of update everybody on where I am and where I think I'm going. So see if anybody's got any suggestions.
Okay. Peter, anything for you tonight? You have to open your mic.
Peter.
I have a quick question, but I might pass because it's a big group. See what it is.
Well, Peter, we always like to hear from you. So let's see how we do, and we'll try and manage and see. David Muslin, anything that you'd like to talk about tonight?
Yeah, I can use a couple of minutes. I've had a rough couple of days, and I'll explain it to you when it's my turn.
With pleasure. With pleasure. Russ Smith, anything for you?
Yeah, just a quick one.
Okay. Jake, anything you'd like to talk about?
No, I'm okay. I'm a little lightheaded tonight for some reason, but I don't know why.
Okay.
I'm okay.
John Hall, anything that you'd like to speak to us about tonight?
Not particular.
John, I just want to make sure, did you get the correspondence I sent you from myself and Alan Adele?
Yes, I did. And I
Okay.
reviewed it in detail, and I've been talking to the medical oncologist about the treatment plan. So I think I'll have a treatment plan up and going next week.
Okay. But you would not like any time tonight, correct?
No, I don't believe so.
Okay. John, would you just do one thing for me? Just drop Alan a note and just let him know that and thank him. I'd appreciate it if you would.
Okay, I will.
Thank you. Thank you. Thank you.
Hey, John, it's Ken Anderson. Can we get together next week?
Sure.
All right, thanks. Sorry, Rick.
That's okay, as long as you stay 6 feet apart, though.
Oh yeah.
You bloody Brit.
Just saying, just towing the line here.
Hey, I have to. This is Jim. I have to jump in with a comment. So, are you guys familiar with Jon Stewart of the Daily Show?
Yeah.
Yeah, of course.
The British guy. He made a suggestion. I don't know if this is going to be funny. It was funny coming out of his mouth, but he made a suggestion for the social distancing that it would be easy if you just assumed that you were a British parent, and therefore, everyone around you were your kids, which means by definition that you keep them at a distance and you don't hug them and you don't touch them.
There you go. Perfect. To that. But by the way, does anybody who hasn't heard me ask this question before, does anybody know exactly why there has been such a rush on toilet paper, and anybody who was on the under 60s advanced cancer group is not allowed to respond?
Well, I have a room right next door, and I've covered myself with toilet paper to here. So I've got 2 more bathrooms to take some out of, so I can get it completely over my head, and then I'm protected from the coronavirus.
I see. Well, there was a fellow, an Aussie, who was on Ken's call, on Thursday, and somebody asked that question, and he told us why there's been such a rush on toilet paper. The reason is because when somebody sneezes, about 100 people shit.
Yeah.
Okay. Now where was I? Peter Monaco, anything for you tonight?
No, Rick, I'm actually, excuse me. I was just, I wanted to join today to follow up on my offer to help out with the site backup. And I never did give Jake a call. He tried to put us together, but I just wanted to let you know that my offer stands, and I'll try to hook up with Jake and find out what it is that you need to do, how I can help out. Otherwise, my situation is stable. There's no change. I'm doing okay.
Fantastic. And thank you. You'll be in touch with Jake. Larry Fish, anything for you tonight?
No, Rick, thank you very much, and thanks for your help earlier. But
Pleasure.
canceled all classes and programs starting today.
Pleasure. Call me if you need any more insight. Les Shelderup, anything for you?
Yes, maybe a quick one. Thanks.
Perfect. Dennis Correa, anything that you'd like to talk about?
Who was that, did you say?
I said Dennis. That's who, Dennis Correa. That's who I said.
All I can hear is a dog barking. I don't need any time. But shut that dog up.
Let's see. Dennis. Len, anything for you tonight?
I'm passing tonight, Rick. I'm good.
Dennis McGuire, anything for you tonight?
Yes, Rick. I have an update on my radiation.
Great. Carl Foreman, anything for you, sir?
Yes, also should be a quick one.
Okay. And Sylvester, anything for you?
No, thank you very much.
Okay. Now, did I did it in a fairly jumbled fashion. I wasn't as ordered as I usually am. Did I miss anybody? Because I may well have done.
You missed Jake, I think.
No, I got Jake.
Did ya? I missed Jake then.
Yes, I did get Jake.
And he did it in the wrong order, but he did catch me. But thank you.
Okay. Jake, you got your boys looking out for you here.
You got it, man.
Anyway, so I think I got everybody. Last call. Anybody I missed?
Rick, this is Jim Ward. I do have one question, but.
Oh yeah. Okay. Well, you'll bind that into telling us a little bit about your dad as well.
Sure.
All right. Well, why don't you start off, and give us your question, and tell us about your dad.
Okay. I'll start with him. He was 90 when he passed away, and I guess the more interesting thing about him is that he worked for the space program during the Apollo missions, and he worked in particular on the Saturn V rocket engines. So he worked. He was employed with Pan Am's Aerospace Division. So I guess he technically qualifies as a rocket scientist. But that was his big. Was kind of his big claim to fame, was being involved in the the earliest Apollo missions, and that's something he's very proud of. So he knew the astronauts, and other than that, his big passion was working on and restoring classic T-birds. So there was other things to know about him, but those were sort of his kind of his two big things. So we're sad to lose him, but he had a good long life and really kept it pretty well together. I mean, he kept it together mentally, all the way to the end, but physically he just kind of started declining over the last, especially over the last few years of his life, and in and out of the hospital with pneumonia and all the things that happen to you when you get to be that age. So we all knew it was coming, and he died in his sleep. So it doesn't, probably didn't get much better than that.
God bless him.
Yeah. Anyway, well, yeah. Well, thank you very much. Thank you. Yeah. So my question is probably going to sound like a dumb one, but they keep referring to people who are at risk for the coronavirus as those who are, immunosuppressed. And I guess it just, let's say people with underlying chronic conditions, including cancer. And I guess what I'm interested in is, to the extent, anybody has sort of gotten a handle on this, is, who are the most at risk among cancer patients? And I'm sure that if you're undergoing chemotherapy, you're probably at some significant risk. But there are many of us that are just on Lupron and one drug or another, right? In my case, abiraterone. So I'm taking some prednisone, which I realize I think is an immunosuppressant. So I just can't seem to get a sense of where we fall on the spectrum. And I know that's asking for too much of a technical answer, but I just don't know the answer to that.
I don't think anybody knows the answer to it at this point, because this is all so new. There's really not a lot of data out there. Prostate Cancer Foundation, that little bit you posted out there, Rick, kind of left it open for the people that have the advance and that are on, the Lupron and Zytiga and so forth. So the data just isn't really there. And I know for a fact, when I did my chemo, my white blood cells crashed, and I ended up in the hospital for a week. So I would just, Peter, caution you. I know you like to exercise and do a lot of stuff, but if you start those periods where you're really feeling weak, I would just take it easy there, because that's the one area where we know for sure. And without monitoring, I guess, my white blood cells get monitored, but that's every 3 months. So I don't know if there's anything else that you could do to really get an individual fix on, your individual situation here.
Well, maybe that's part of the answer, is looking at your, white blood count, for example. And I know I'm sort of within range, but at the very low end of it. So I guess I could answer my own question, perhaps, to some extent, that, it's just, you got to be careful. And, I'm not engaging in any, social contact or interaction at this point, like a lot of people, just to play it safe. And I'm not gonna engage in non-essential travel. And I don't know. I guess in the end, it's a hard one to gauge, as you said. We don't really have the data.
Anybody else in this group? I do have something to say, but I'll wait. Does anyone else in the group have any comments they'd like to make on that?
Yeah, I've been doing monthly blood tests for years now, probably about 4 years maybe, every month. I watch my white blood cells and other markers. Now I'm doing it every 3 weeks because I'm on chemo, and I do have to do it. I just did it today, my infusion this week. So I think it's helpful to keep an eye on your blood counts and everything else. If you've got, if you're on drugs and so forth. I know I went into anemia right away when I went on androgen deprivation, and that included white blood cell count.
Jerry?
Well, Peter, I'd like to reiterate what Rick said. Traveling while you're between 4 and 5 chemo is probably not a good idea. Traveling for 5 hours on a plane is probably not a good idea. But for you, Jim Ward, going and seeing your wife in Tallahassee, Florida, yeah, I don't know. I'd probably give it some consideration. I'd go visit her, but that's just me.
Ken, you might You might want to tell Brian that. He told me
Tell
last-
who?
Brian's flying to Maui, but
Yeah, tell Brian that. He called me last night and said he's coming over on Wednesday.
oh, he is flying. Well, of all places, Maui's probably not a bad place. There's not a lot of people there. It's probably a pretty safe place to go.
Oh yeah, we only have 50,000 tourists on any given day from all over the world.
Troops? No.
Yeah,
Well, then you're sequestered. You're not out running around with the troops.
right.
So, Jerry, did you want to say something just before?
Well, just that, I think that I've determined that I'm compromised times 4. And to kind of nail that down for you, I'm immunocompromised. I'm over 70. I've got the underlying condition of cancer. I'm taking chemotherapy, and that's why I'm immunocompromised. And then I have cancer in the lungs, so I have the additional respiratory complications. So, needless to say, that puts me in a very vulnerable category. Probably a worst case scenario as far as maybe not coming back from this if I caught it. So I'm taking a lot of precautions to stay away from other people and do all the things that we hear about every day. But I don't think everybody is in the same classification that I am. And I think that if you're not taking chemotherapy or you don't have cancer in the lungs, then and that reduces, all of those things would click off some risk as you look at your overall risk factor.
Mm-hmm.
Yeah, well, that certainly makes some sense. So I guess it's safe to say we all just need to be. I know we are. We're all being thoughtful and mindful about what we're doing and not taking any risks that you don't have to.
So I would like to refer you to the link that Dennis mentioned that I included in the reminder, which is the PCS, the Prostate Cancer Foundation mailing that they sent out as to their opinion as to how at risk men with prostate cancer are. And what I just want to read, I mean, we all know that if you have chemotherapy, if you're on chemotherapy, that is a significant risk. And, if you're in early stage prostate cancer, probably not much of a risk, but the issue is, what about those guys sort of in the middle who are on hormone therapy? And let me just read to you what they say. They say, if you're on a form of hormone therapy, there is no published evidence of increased risk of severity of coronavirus infection. Extensive research in tens of thousands of patients on medications such as Lupron or Zytiga or Xtandi shows there is no evidence that these treatments put a prostate cancer patient at higher risk of other viral infections like seasonal influenza, the common cold, or hepatitis. Experts feel the immune cells are normally functioning in normal virus infections in men on hormonal therapy for prostate cancer. It then goes on to say coronavirus, however, is not a normal virus, and there is no new data on hormonal therapy with COVID-19, but there's not much evidence of COVID-19 with any type of disease. But I think the point here is that, yes, we do know that on long-term hormone therapy, your white blood cell count does get a little compromised. Your red blood cell count does, because you become marginally anemic. But I just want to stress that I maybe read it a little differently to Dennis. And what I see here is they're saying we can't be specific about COVID-19, but we can tell you that these drugs should not be compromising your immune system. Len, do you want to have the last word? Len, do you want to have the last word on this?
I might disagree a little bit with what PCF is saying, because I'm sure most of us on ADT see our white blood cell counts go down and our lymphocyte counts go down. And those are the two major immune cells in our bodies. Maybe it's just a theoretical risk. And I guess what PCF is saying that empirically they don't see an increased risk of infection in those folks. So maybe they're right. But I know I definitely have lower white blood cell counts and lymphocyte counts, and I'm sure most of the guys on ADT have experienced the same thing.
Okay, well, let's just get, we need to keep moving along because we do have a number of people that would like to talk tonight, and we could probably keep talking about this for a while. So I'm going to move on, and I'm going to ask, let me see, we spoke, that was Jerry we just spoke with, right? If I'm not mistaken, Jerry, did we just speak, was it you that just, no, it was Jim Ward that raised that issue. So Jerry, why don't you give us an update and tell us where you are?
Okay, I'll fast forward through the first 20 years that I've had this cancer and go to year 21. So along that 20 years, I've had surgery, I've had radiation proctitis, I've had lots of bowel obstructions and adhesions, I've had hormone therapy. I found my way to Snuffy Myers and stayed with him for a good long time. And then Snuffy referred me to Charles Drake up in New York City. He's currently my quarterback doctor. I have had CyberKnife to a fairly large nodule in my lungs back in the summer of 2018. And I almost got into a remission with that. But in February a year ago, my cancer started doubling every month. It started at 0.7. And before we got treatment started in December of this past year, it had doubled to 36, which is the highest I ever saw it, or never been above 3 or 4 for me. So that was really quite alarming. But we did get chemo started, where it's not clear yet that the chemo is really knocking the gonads out of this cancer that I call Boris, the stupid one, because it takes a stupid cancer to want to kill its host, you know. So anyhow, we got the PSA. The first measurement of the PSA was in the end of January, and it came down to 28. So I got another PSA today. We'll see what happens in a day or so. I'm doing an Oxyman PET scan on Thursday of this week to clear up whether or not some activity that we've seen in a CT scan of the lungs is metabolically active or not. So I'm getting that done Thursday, and that should give us some indication of whether or not the lesions that the CT scan pointed to as suspect as possibly growing rather than getting smaller, or whether they're metabolically active or not. So I will probably go through the 6 treatments because I've done 5 now, and we'll take another one in 3 weeks, and it's docetaxel. But I may be looking for another rock to hop to pretty quickly. You know, it could be a clinical trial with Drake up in New York or somewhere else, and I don't frankly know just what that will be or how bad I will need it or how quickly I'll need it. So I'm keeping a lot of options open. I'm holding my plans loosely to be sure that I'm flexible and willing to go in any direction I need to go. That's pretty much a quick update, and
So
there's not a question there, but if anybody hears anything that you'd like to comment on and suggest that I might want to be looking into over the next period of time, then I'm wide open to hear that.
Well, there are a couple of things I would like to add for those who are not familiar with Jerry, and that is that Jerry had a very, very unusual form of our disease in that it showed up very early in his lungs, and it's danced around his lungs on and off for probably 15 years or more.
2006 is when we found it. It was probably there before 2006. So,
right. So, and the other thing, of course, is as Jerry mentioned, he never produced much PSA until just recently, and yet nothing seems to show up when we sequence and when we look for why Jerry's type of cancer might be different. We can't really find anything. So it is a very intriguing and different type of situations. With that, let me throw it open if anybody would like to ask Jerry any questions.
You know, mine, Jerry, would be more not towards disease, because I know your battles. It's Ken Anderson. I know we've never chatted. I've been on here for about 3 years. I'm more interested in Charles Drake. How is he personally? Is he a good guy?
I have really no complaints. He's very accessible to me. I can text him and get a response from him usually in 5 or 10 minutes. And he has, so I texted him today. I said, 5th treatment completed, PSA measured, should get a result in 2 days, Oxyman PET scan on Thursday. And in 5 minutes, he's responded back to me. Awesome.
I think that's
Wash
great.
your hands frequently.
Yeah, I think that's great.
There's been a lot of other times when the response that he gave me was much more technical or directive than that. And whenever I've needed to talk to him on the phone, he would set up a call, sometimes late in the evening after he's gotten out of the lab. And but he would talk to Patsy and I. He would let me record everything that all the meetings we've had. I've been able to record him so that I can listen to those meetings and over and clear up any confusion. But I've been very pleased with him.
Well, that's good to hear. I know MD Anderson had given him a thought for a second, I believe, but I think he's a great guy. I just never met him personally, but I'm glad to get the info on him. Thanks.
And one thing that does come up here, which is probably going to be helpful to everybody, which is that Jerry has learned, and Jerry and I have talked about this a few times, that the more terse you are and direct, the easier and quicker it is to get an answer from your medical oncologist.
Yeah, that's without a doubt. That's correct. He went dark on me for a period of time when a guy had got a little verbose. So I keep it very brief. I think he was telling me, well, yeah, let's just cut to the chase here.
Yeah, and I think that's a great thing to keep in mind for all of you when you communicate with your docs. As much as they might like to talk to you, they're all really busy guys and they all want to help you, but you know, they're not really that interested in what you have for breakfast. Anyone else like to talk to Jerry before we move on?
Jerry, this is Len. 2 questions. What was your original Gleason score?
3 + 3.
Wow, that is seriously unusual.
Yep.
Yeah.
So the other question was, was there any consensus from all the doctors you've seen over the years on the significance of someone like yourself who doesn't produce much PSA?
Well, at one point, Myers and some other people that I talked to thought that when we found it in my lungs that I had a neuroendocrine phenotype, but Dr. Myers ruled that out with a chromogranin A test. So he that was a test that he was using to measure how aggressive the cancer was, and mine was, I believe his cutoff was 30, and mine was, well below that. So he said to me that there, in the full time that he had been practicing, he'd only seen 1 or 2 people like me. And while I had a cancer that was moved along slow for many, many years, it wasn't a cancer that he felt like we should let get any stronghold in my body. So we've treated it very aggressively all the way.
And so just one more question. I'm sure you've had more than just one biopsy, more than your original biopsy, tissue biopsy. Did they ever upgrade your Gleason score on the subsequent biopsies?
Gosh. That's a good question. We had a biopsy of the lung when it came in 2006, and that was confirmed to be prostate cancer. They did do a biopsy of T11, which is where I have a lesion right now. And that's a good question. I think I need to go back and check to see if that Gleason has been upgraded. They did get enough to confirm that it was prostate cancer. They did not get enough for Foundation 1 to have a sufficient sample to sequence it, which was disappointing.
Yeah.
Just a quick comment on that 3 + 3. I mean, the 3 + 3 is down to the fact that they never spotted the 4. I mean, there was probably 4 in there somewhere, and they didn't see it when they did it originally. It happens. We need to keep moving on, and I'd like to go to Peter, because Peter's our other guy who's currently in chemo. Peter, thoughts for Jerry, and what's on your mind?
Yeah, I'm doing the double whammy. I'm doing docetaxel as well as carboplatin, Neulasta, of course. So my number 2 day in the chair is coming up this Thursday. So my question is, it's like everything, all the stars are in alignment this week. So not only am I doing chemo this Thursday, but I'm due for my Lupron shot, my 3-month Lupron shot, as well as a Prolia shot. And the hospital is not my favorite place to hang out right now. So if I can go once every 3 weeks or twice in 3 weeks for doctor appointment as well as chemo. Do you think I'm stupid doing all the Lupron, the Prolia, and the chemo all in one day? Or do you think I'm asking for trouble?
Anybody else here done all that on one day before for whatever reason? Anybody who's had chemo done everything on one day before? You're muted, Jerry.
I said I had trouble hearing Peter. It's coming through muffled. But that's maybe you tell me, Rick. I hear you well.
So Peter was saying that the stars are all in alignment, and he's going to get his Lupron shot, he's going to get his bone strengthener shot, and he's going to get his chemo, all scheduled for the same day. Do we think that that makes sense or doesn't make sense?
Today I had the Xgeva shot. I had the chemo, and tomorrow I get the Neulasta, which is the immune system booster. And I'm doing the Eligard every 6 months, so it didn't line up like that, but it's pretty close.
Yeah.
Peter, I would just say, of course, I'm not in that same situation, but it seems to me that the fewer doctor visits you have, the fewer chances you have to expose yourself to coronavirus. So, do them all at the same time if you can. I assume it's the same doctor, correct?
Yeah, it'll be done at the hospital.
Oh, you have to go to 2 different places?
No, it'll all be done at the hospital. In the intensive room.
But you limit yourself to 1 visit instead of 2 or 3.
Right.
Well, Peter, I can say I had Lupron and chemo on the same day on one of the treatments. I had 6 treatments just like you. I didn't notice anything different. It was like the 3rd round of chemo. I didn't notice anything different when doing chemo and Lupron on the same day, but I don't know. It seems like it's a big stress on your system for sure. I probably have you by 10 years. I don't know your age 100%, but I'm just about 60. So I don't know. There's 3 things. You're saying Lupron, chemo, and Neulasta?
Neulasta and Prolia.
Prolia.
Prolia is Xgeva. Prolia is a longer version of Xgeva.
I'd be worried about maybe the Xgeva, but I don't know why. Xgeva caused me joint pain, but I think chemo caused me joint pain. I don't know.
And Neulasta does for sure. Yeah.
Yeah, I don't know. That'd be a doctor.
The disadvantage of that is if one of them is causing a symptom, you'll never be able to sort that out. That's for sure.
Very true.
I'm gonna bounce it off my oncologist. Send him an email and just make sure he's on board with it.
Right. But by the way, Jerry, have they not, when they give you your chemo, they don't put one of these little Neulasta gizmos on your arm so that you get it automatically?
No, I'm getting a generic shot. It's not Neulasta per se, but it's I forget what the name of it is, but it's a Neulasta-like drug that they give to me with an injection.
Okay.
Would that be Neurontin?
I'm really blocking on it right now, to tell you the truth.
I think Neurontin is a completely different drug.
Yeah, I don't believe
Neurontin is the same as gabapentin.
Yeah.
That's right.
Right.
So Peter, do you get the Neulasta on your arm when you finished chemo?
Yeah, it's like a little patch that automatically injects it 27 hours after your chemo.
Yeah, that's the same I had.
Yeah. Okay, I'm done.
Okay. And it was a bona fide and very worthy question, Peter, and I'm glad you asked it. Okay, let's move on to David Maslin. David, what's on your mind today?
Okay, guys. So about a week ago, maybe about when I did that first meeting, I was just starting to get side effects from the Lupron shot, which I had exactly. It'll be 4 weeks on Wednesday. So all of the hot flashes started coming on. Would be up at night. It wasn't sleeping well. and kind of living with it, but it was okay. Just all out of sorts. But when this whole coronavirus thing really started hitting, and then I had anxiety that was crawling through my skin. I was so hyped up on anxiety. I've never felt anxiety like that in my whole life, all throughout my body. Peter's shaking his head like he knows what I'm talking about. And I was crawling out of my skin last night. I finally called my internist, who's a personal friend of mine, and he got me some lorazepam, which really calmed me down. I took one at 10 this morning and another one at 4, and I was totally functioning, and even the hot flashes seemed to have died down. But it was the anxiety was actually painful in my body. It hurt so bad.
Mm.
And he suggested that I get on a drug called citalopram. Citalopram, anybody familiar with that? Spelled Citalipram.
Yeah, citalopram, it's an antidepressant.
It's an antidepressant. I have always been big on taking no drugs. And so I'm not sure what to do. I don't know if I want to get on that or just, the lorazepam I know is a controlled substance, I found out today. But it sure helped me when I took, one at 10 o'clock and one at 4 o'clock, 5 milligrams. Any input, suggestions?
Yeah. David, that I've worked in the mental health field, and lorazepam is a benzodiazepine, okay? It's one of a class of benzodiazepines. They're good for short-term relief, but it's not a drug that you want to rely on. At least this is my opinion. It's not a drug that you want to rely on in the long term. Moving to an antidepressant, might be a little more difficult to get that kind of results. You won't get an immediate results often from an antidepressant. It will take longer. It'll be a little more difficult to titrate it and determine, what the right dose for you is to ramp it up, ramp it back, or whatever. But like I say, you want to stay away from the benzos. They can be addictive and can take more of them to do the same, to give you the same effect over the long term.
Right. And so, how do you pronounce it again?
Citalopram. The trade name is Celexa.
Okay.
I agree with Jerry, David, that it's a safer drug than the lorazepam. Any of the benzodiazepines you can become psychologically dependent, if not physically dependent. And also their known, long-term use is known to result in cognitive deficiencies.
Yes.
So
I'm thinking of even getting on an antidepressant. I thought maybe it's just, just a short little period that.
Okay. So David, let me give you some thoughts on this, and I really would like some other guys to chime in afterwards. And I'm taking more of a bird's eye view. We know that the LHRH drugs as a whole can easily impact your mental stability. It's really well known because I guess amongst other things, that they certainly affect the androgen receptors that are in your brain. You don't have the testosterone in your body, and so your brain so these androgen receptors are not picking up testosterone as they did, and it can have a significant effect. Now, just the same as when women go through menopause and some of them become Not everybody, but some women become a lot more emotional. Many men, when they start on an LHRH, truly become a lot more emotional. It's, you know, we make that point in the pamphlets that we sent you, and I think that you have to take that to heart. This is not you. This is the drugs you're taking, and you have to consider that if you God forbid had the flu right now, not COVID-19, just the regular flu, you probably would, you know, you might take aspirin. So you have to think about this as taking a drug to help you with a side effect that's being caused by your treatment. Now, in my own case, and the guys have heard this before, I have a lot of depression in my family, and I have probably been chronic depressive most of my life, and I never wanted to go on drugs. And finally, in 2000, I did start taking an antidepressant, and the first one I took was the worst. It made me feel even worse, and I got off of that, and then I started taking another one, and that one has balanced me ever since. Now, when I went on Lupron in 2007, my dosage wasn't right, and I was fine at times, but at other times I was very depressed. And, you know, the good thing was I knew the black cloud. I knew what it was like. I knew that it wasn't the end of the world. But for men who have never known depression before, or anxiety for that matter, they don't know what's hit them. And I strongly, I can't give you medical advice, but in my case, I went to my doc and I said, this is what's going on. He doubled my dose. And I would hope that any man that suffers from anxiety or depression as a result of taking an LHRH drug speaks to their doctor and considers taking some type of medication, whatever is the right one, until they feel balanced. So don't put it on yourself about having never taken drugs. It's going to make your life so much easier if you find, but you're going to have to find the right drug, and it may be the Celexa is not the right drug for you. You won't know until you start. You may have to switch again. Give it time, find the right drug, and keep taking that drug. Who else would like to say something?
I have a comment about this. This might be a little bit controversial. When we talk about, you know, with advanced disease, getting a good genitourinary medical oncologist, I think it's just as appropriate to have a good, knowledgeable psychiatrist on your team. Someone who's in outs of drugs, who you can talk to, who's not pushing anything and not over-medicating you, but you can actually sit down and have an intelligent conversation and talk about the pluses and minuses of different things. I've got one. I see his wife as a therapist once a month or twice a month, but I see him maybe twice a year, you know, to renew a prescription for a low-level antidepressant. So it's I find it useful. I've been doing it for probably a number of years. Not only that, I've educated. He had no experience much about prostate cancer, but the three guys that I work closely with have come to me as a result of him. You know, people going to him for help, and he's kind of sent them on to me for, to consult about prostate cancer. So it's useful doing the research and seeing if you can get somebody on your team.
Yeah, so the question I was going to ask is this was prescribed by my internist, and I never even spoke to Maha Hussein about it. And you're thinking maybe it's smart to talk to a psychiatrist, or should I talk to Maha Hussein and see what her experience is, or just try this?
I would definitely somebody.
I would definitely talk to Maha Hussein, because she prescribed the LHRH drug. She's very familiar with the side effects. She may say, look, it's not me that can prescribe the right drug for you and refer you to somebody. It may well be that there is at a center like Northwestern, they probably have some psychiatric oncologists there, or oncologic psychiatrists. I'm not sure which way around you put it. I know they do for sure at Memorial Sloan Kettering.
Yeah.
So my guess is they do. And if that were the case, I think that's who I would want to see, because they have the most experience of prescribing a drug, the right psychiatric drug, as a result of being on an LHRH. So I think I would probably start there, and use your internist as a backup. Jerry, you've been wanting to say something.
Yeah, Peter raised a good point here. You see this psychiatrist's wife for therapy. There are some therapies that will help you manage the anxiety. One is cognitive behavioral therapy. It helps you to reframe the anxiety. It helps you to how would you say, normalize the anxiety to some extent.
I'm wondering if Jerry's Jerry.
I'm sorry, I got somebody's trying to FaceTime me. But,
okay.
So you know, to find someone who would help you adjust some drugs or some anti-anxiety approaches, but at the same time, finding someone who would help you manage the anxiety from a therapeutic point of view.
Yeah.
I think that combination is a winner combination, because I don't believe that drugs in and of themselves are a long-term solution to anxiety, but that's my bias.
I agree. I agree, Jerry. And as you and I spoke, meditation in the morning helps me a lot.
Sure.
Yes.
But this got so out of control so fast.
Yeah.
It's just overwhelming.
Well, this is the perfect storm for anybody dealing with anxiety right now.
Yeah.
And I mean, it's just, you freak out in so many different directions, and you don't know what's coming next, because it's changing on an hourly by hourly basis.
And I quit watching the news. That helped a lot. That helped a lot.
David, have you you look like you're an exerciser. Have you been exercising through this anxiety or not?
Big time. Work out every day.
Okay.
Yeah.
How about aerobic exercise?
I ride a bike, and I swim, and I run, and I lift weights. But I will tell you, my weight dropped about 3 pounds in the last 4 or 5 days.
Okay.
That could just be inflammation too, because I've been eating super clean.
Yeah, but I mean, I think it's also anxiety and depression. I know when I feel pretty lousy, I drop weight really quickly.
Yeah.
Just we'll go to one more person on this. I think Carl Foreman has wrestled with this issue. Didn't you, Carl, when you went on the LHRH, you know, it hurt you mentally initially as well?
Yes, it has, and I requested of my primary care doctor something to help me with the anxiety, and he put me initially on 50 milligrams of sertraline, also called Zoloft, and about a month to 2 months later, I had a follow-up appointment with him, and he asked me how he was doing on it. I said, well, I think maybe we should increase it. And since then, I've been on 75 milligrams. I think it's helping. I'm dealing with things as well as I can, but I don't want to consider it as a crutch per se, but I'm not anxious to get off of it anytime soon.
Right. Okay, anyone else got anything really significant or want to share an experience before we move along?
Thank you, guys. You're awesome.
It's a pleasure, and as they say, this too will pass, David. I mean, look, we've had guys, you know, guys on LHRH will tell you they suddenly burst into tears. It's never happened to them before, and they can't understand why. Well, that's the reason. So if these things happen to you, don't beat up on yourself. Accept that it's part of the treatment, and you'll manage it in time. You will manage it in time. I'm certain about that.
Learn to cry. Learn to cry elegantly, David.
I like that.
That's what I'm going for.
I like that. I like that.
Thank you, Rick. Thanks, everybody. And thank you, Jerry. I hear you on the benzos, Jerry.
Okay. All right. Let's go to Russ Smith. Russ, what's on your mind today?
1 second. Let me make sure I'm off mute. Okay, I'm good. So I'm 1 month into ADT and finding the same things that you guys have been talking about. I'm on Zoloft, but I hate taking it. I did send my paperwork in today to go on. I'm in New Hampshire, and we have statewide medical cannabis. That I'm going to try that instead of the Zoloft or lorazepam that both have been prescribed to me. But I'm, because of the meds, I'm feeling depressed, and the last few days, my legs are real sluggish, along with my mind. So, just trying to get used to the, to the new meds, and I go back for my second Lupron shot in a week and a half. That one, I'm not sure if we're going to do. The first one was just a month. I think the second one, I think they may go for a 3-month one, but I'm not sure yet. And now with all of the coronavirus issues, radiation is supposed to start May 4th. And for those who don't know, I'm 1 year out of surgery. I had RALP February 5th, 1919. And then PSA started rising, so went back in and re-diagnosed cancer, come back, and that's why I'm here tonight. But so basically, it's just getting used to being more tired than normal. Legs aren't working the way they used to. The mind is a little bit slower, a little bit tireder than I used to be. This is all part of the process, I guess. So, I'm just trying to get through it. And if anyone has any great ideas, I'm working out, I'm eating good, so I'm doing what I'm supposed to be doing, but it's still getting to me. So if anyone has any great advice, I'd love to hear it.
When I first met Rick Davis, it was in Mill Valley, California, and I just started Lupron, and he took me on a hike on Mount Tamalpais, and I didn't know if I was going to get out. I mean, I call it Lupron legs. I mean, you feel like the mummy. You just feel like a drag in your legs. And you will get past it. It'll get better. But don't go on a hike with Rick Davis.
At the same time, let me tell you, you should go on a hike with Peter Kafka, because he was kind enough to buy me a lifetime pass to the national parks, for whom he worked for many, many years. Yeah, I want to just go back to something I said to David Muslin, which is that I really do encourage everybody to try and find the right, what would I call, psychiatric drug. Whether if it's an antidepressant, the right type of antidepressant, and it may be that the Zoloft isn't the best drug for you. And I'm not saying that the medical marijuana, I mean, I'm a big proponent of medical marijuana, but my concern here is that this is an underlying situation that you're going to be living with for the next several months whilst you're on LHRH. And if you can find a drug that works for you, you'll be better off and use it with the medical marijuana and not use the medical marijuana instead of the drug. And I think I would be talking to whoever prescribed the LHRH, like we suggested to David Muslin. I might try and get a virtual appointment with the psychiatrist at Dana-Farber, because there is going to be one down there, and try and find that right drug that is bad for you. I mean, they put me on Paxil. I was bloody suicidal because it just wasn't the right drug. Then they switched me from an SSRI to an SNRI, and I felt so much better. So, you know, a lot of this heaviness in your legs, frankly, is probably related to the depression. I'm not a doc. I don't know. But I can tell you from my own situation that the more depressed I get, the heavier I feel and the more fatigued I feel. So that would be my advice, is to try and find the right drug for you, and don't be afraid of taking it. Anyone else want to comment on that? Len, what are your thoughts?
I agree with everything you just said, Rick. Sometimes you just need to switch to another drug in the same class or a slightly different class, as Rick was talking about. And where one doesn't work for you, another one will.
Okay. Thank you, guys.
Yeah, I also wanted to add that I had a relatively recent experience with medical marijuana here in New Jersey. I've never smoked, so I had a edible, and what was offered to me was it tasted like a mint. It had 5 milligrams of THC. It had a nighttime version and a daytime version. I was on the nighttime version to help me sleep. I started with one one mint of 5 milligrams. A couple of days later, I went up to 2. It seemed to help. And then when I went back to the dispensary, they said, oh, well, now we have a daytime version. So I bought the daytime version. So the one time I had 2 at the nighttime, and then the next day I had 1 of the daytime. So that's a total of 15 milligrams of THC, which I don't think is a huge number, but I felt so out of sorts. I never felt that way before. I told my oncologist about it, and he said, well, because you've been on the Zoloft and the occasional tramadol that I've needed for occasional pain, he believed that there was a negative interaction between them, and told me to stop the medical marijuana. So that was my experience.
I think sometimes people pile on stuff, and you don't know what's working and what's not working. And I guess I have a bias away from drugs, and letting your mind, letting the resilience inside of you work on this as well. And that's why I say, don't get on benzos. The long-term solution, or the best solution, is for the resilience that is a part of each and every one of us to embrace the condition, the situation that we're in. This is my personal belief about this. Dr. Myers almost put me on Lexapro because I was having situational depression about finding the cancer in my lungs, finding out that I had metastatic cancer. My son's a psychiatric nurse. I asked him, I said, what do you know about Lexapro? He said, Dad, if you can stay off of the drug and let your mind let your spirit, your mind, your spirit, um, embrace the condition that you're in and learn to cope with it without drugs. You'll be better off. It was good advice for me because that's precisely what I did. It took longer. It took some digging for the things that had brought anxiety into my life, all of my life. But this is just an alternative view. You can take it or you can leave it. But I worry about, when you pile on drugs that have a psychoactive impact on you, a lot of times it's just trying to figure out what's the next best thing to try. I think if you're going to use a psychoactive drug, get it from a psychoactive specialist and not necessarily a primary care doc, because they haven't been trained in these drugs. Psychiatrists have. So if you're gonna use them, try to find a psychiatrist, but try to find a good therapist too, that will help you help your mind.
So this is a perfect segue. Thank you very much, Mr. Deans.
I'll shut up now.
Into the promo that we're going to do for Thursday. For Thursday night, for those of you who have never joined us on Thursday night once a month, and it's this week, we have a group called Speaking Freely, and that group is to talk about everything that is troubling us and that is on our mind other than the actual treatment. It can be a result of the treatment, but we don't want to talk about which is the best LHRH drug. And it is a very good group. I'm hoping Jerry might be present. Rich Jackson moderates it. I help along, and the time is 8 o'clock Eastern, 7 o'clock Central, etc. And the same channel. And we would encourage any and all of you to tune in. It is a pan-cancer group, so hopefully we'll have people from other cancers living with other cancers as well. But I will say that traditionally it's been mostly prostate cancer guys, but that's because of where we come from. So I'm going to keep moving along here, make sure we get to everybody. Dennis McGuire.
Yes, hey Rick. So I just an update on my radiation. So I'm moving ahead with radiation of the prostate, including the seminal vesicles, and also radiating a lesion on a lymph node in my pelvic area, which I guess they call the iliac lymph node. The type of radiation is going to be SBRT. I go in later this week to get the markers placed in the prostate in advance of the radiation, and don't really have a date set on the radiation. It's really going to be all subject to availability once I have the CAT scan after the markers are in place.
Okay.
So that's kind of the update. I guess if there's any advice or any watch outs for those on the call that have been through radiation, be helpful.
Yeah, I'd like to talk, especially I'd like you to talk to anybody who has had the prostate gland radiated later in the treatment, not at the beginning of the treatment. Ken Anderson certainly fits into that one.
Yeah, and just for background, so I've been into this for 4.5 years. I was diagnosed end of 2015.
Okay. Go ahead, Ken.
Rick, I just sent Russ a message, I do want Russ to not discount depression, though, when he's on his LHRH trucks.
Right. Right. No, we agree. But can we talk about Dennis?
Yeah. Dennis McGuire, yeah. Radiating your prostate gland for sure. I had the same thing done probably a year after starting Lupron. I mean, and planning the markers and going through, I had IMRT. I mean, I think it's called RMRT. It was painful, not painful. It was a long process for me. It was every morning for like 2 months. But I must admit, it took the gland out of the equation. I had some inflammation on my last PET scan that I thought was prostate cancer in the gland, but after doing a second biopsy and confirming that it wasn't, I was pretty happy that I went that route. I'm pretty confident at the moment. I don't have any cancer kind of fluffing off the prostate gland at the moment. Most of mine is systemic through bone mets and lymph nodes. So I think the approach, and it's not something that most places other than maybe Mayo at Rochester, I think they're the only ones maybe 5-10 years ago that were actually addressing the gland. So I think it's something today that you should definitely consider doing, and I'm happy you're doing it.
There is a product that I would. I'm not sure if it's relevant in your case because I missed. I know that they're doing a lymph node, and are they actually radiating your prostate gland too?
Yeah, yes, they are. Yeah, it's a full prostate radiation. Yeah.
Have they mentioned a spacer gel placement that they can put between the prostate gland and your rectum to protect your rectum? Have they mentioned that as a possibility?
Yeah, I did have that conversation with the radiation oncologist, and after looking at the MRI they did, he does not want to use the spacer because the tumors on the prostate are right up against the rectum, and he doesn't feel he has enough room to put the spacer in. So the risk of putting a spacer in is that he cuts off he interferes with the tumor and it doesn't get radiation.
Yeah, that was the same with mine, Dennis. We talked about the gel spacer. It was not something that they felt. Jerry, I don't remember Jerry's last name, but yeah,
Lucas.
Yeah, Jerry's been doing it for like 30 years here in Phoenix, and he's really not everyone can find benefit in installing the spacer, but it's great for those that do, because it protects, the rectum, lots of things if they can. So as long as he's chatted with his radial oncologist, then I think he's good. I think
this is Jim Ward.
Go ahead, Jim.
I was going to say I was also in the same boat. So they did not do the spacer, I think, for similar reasons. But one thing I would mention is my radiation oncologist did insert this every single treatment. They inserted this like balloon, that then filled up with like saline or salt. I think it was a saline solution. And the idea was to sort of create some protection or. Anyway, I don't know if anybody else is familiar with this, but that's what they did to me every day.
Didn't even notice it, but yeah, it occurred. And Jim, I want to let you know, Jim went to MD Anderson in Houston, so they had some of the some of the more informed radiation oncologists. I wasn't sure when I got mine radiated that I had the right guy, but after the fact, I found out Jerry's kind of a rock star here in Phoenix for this for this kind of treatment. So I'm sure you'll handle it pretty well.
Dennis, did you ask them about whether they were going to treat the whole pelvic girdle and what their rationale was on that?
Yeah, we talked about it, and they recommend not doing it just because of the distance, the metastasis I've had previously, where I had lymph node involvement as far up as my left clavicle.
Right.
It doesn't show up on scans anymore. So we weighed the risk trade-off, and they feel that doing the pelvic girdle is adding additional risk with not that much benefit, and potentially we could just do spot radiation in the future if needed.
And this is going to be how many treatments? 4, 5?
I think that what they want to do is they want to alternate the treatments. So 5 treatments every other day on the prostate and vesicles, and then every other day on the lymph node. So we'll go 10 consecutive days.
Okay. Okay. Well, if you're not getting the pelvic girdle radiated, you may have less fatigue, because I think the bone marrow gets impacted more when the pelvis gets radiated, and that obviously would be a good thing. Also, you may have a little less digestive issues. I really don't have enough experience with SBRT to know how it compares to IMRT. So you may sail right through it without any side effects at all. But if you do, you'll call us, and we'll have ways, or you'll reach out to me, or you'll come on the call, and we'll have ways, I'm sure, to mitigate some of those risks. Anybody else want to say anything to Dennis about the treatment?
I want to echo something you just said, Rick. I talked to Dr. Brian Collins up in Georgetown, who is the guy that administered SBRT to the lung nodule that I had back in the summer of 2018. And we were talking about him doing SBRT on T11. And he said it was an ideal target, because he said if it was growing and it grew, then it would get into the spinal column and, impact my ability, my spinal integrity, so to speak. And I asked him about a lesion that I had down on down in the iliac bone, left hip. And he said exactly what Rick just said, which was he wouldn't recommend treating that because it would have the impact on the bone marrow. And, that it was very important to consider and factor in the amount of bone marrow that you are disrupting with SBRT. It can reach a point where you impact other things by how would you say, over treating the bone marrow. So he didn't take me to school on that, but he did say for me he wouldn't recommend doing both of those bone lesions. And the one on T11 was most critical because of its the integrity of the spinal cord or spinal column.
Yeah, thanks, Jim. Anyone else have anything that they'd like to add for Dennis?
Well, Rick, Dennis and I spoke for about a half hour on the phone earlier today, and I was recommending to him that he speak to the radiation oncologist about whether or not to drink water before each procedure to fill up the bladder to keep the prostate in the same position. And so he said he was going to do that. But I'm just wondering, of the guys on the call, of those who've had radiation, what was the recommendation for you regarding filling your bladder before radiation?
Right.
You know, I can say for myself, Lynn, it was a comment that was made, but you know, the difference between IMRT and SBRT, I think, are pretty substantial. I don't know. You know, the
Well,
amount of
yeah,
radiation.
there is a difference, but the bladder, in any case, could move the prostate around. If the bladder is small or if it's large, you know, it's going to have an impact on where the prostate is.
Well, to make a comment, then yes, they advised me to drink tons of water before I went in. And if I didn't have enough water in my bladder when they did the imaging, they made me drink more.
Okay.
Yeah, this is Jim. Again, I had the IMRT, and that's what I also had to do as well. And you know, it was one of those things that a lot of guys would go in, and as Ken mentioned, they either didn't have enough in their bladder, or in which case they had to drink more and wait, or you had too much and you had to void some. So I don't know how much detail you're looking for, but you know, in my case, they gave me a sort of a recommended amount of water that I had to drink, you know, within by an hour or an hour and a half before the procedure. And I got it down to a science. I think many guys do manage to kind of figure out where they need to be in terms of the volume of water and by when they need to have consumed it, so that you're coming in there and you're hitting your number and you get in and you get out, you know, with your treatment. So I don't know if that kind of answers your question, but it became a bit of a challenge, I guess. I'm a competitive guy, but I never like to miss my mark.
Yeah,
that's helpful. Yeah, that's
interesting.
helpful. How do they measure the bladder? Do they do like a ultrasound or something?
Yeah, they do an ultrasound.
It's interesting because it was never mentioned to me to fill my bladder. Now I did have markers, and I mean, I do believe that those markers, by triangulating on the markers, that they can identify where the prostate is. So if the prostate is moving, they can readjust the equipment all the time. So I have to say I've never properly understood with the technology of the markers why you have to fill your bladder. But my doc never mentioned it.
Yeah, this is Jim again. I know Rick, yours was you know, some years ago. I mean, that was absolutely the drill at MD Anderson. I mean, it was kind of I don't know if comical is the right word, but you'd have all, you know, on any given morning, you know, I go in there and there'd be 3, 4, 5 guys kind of waiting their turn, and everybody was, you know, going into the room to get the ultrasound before they would go get the treatment. And guys were, you know, either coming in too low or, you know, and then having to drink and hang out until their bladder filled up. And it was just, you know, this guys hanging out, and they either came in too low or they came in too high. And it was just, everybody became very obsessed about the ritual of, you know, how much to drink. But anyway, the point is, it was very standard operating procedure.
Yeah, I mean, don't get me wrong. When I had my radiation, many guys were filling their bladder. So it wasn't anything that was out of the ordinary, but for my doc, he didn't think it was necessary. So, you know, again, I think it depends on the doctor, it depends on the institution, it depends on the type of radiation that you're getting. Anyway, I do want to move on. We got 20 minutes. We've got two gents to talk to, Carl Foreman and Les Schelderup. Les said he had a quick one, so Les, let's go to you first.
Okay, this might be a little bit premature, but I have a little concern. I was diagnosed with Gleason 10 about 7 years ago. I've had various treatments, and after the treatment, the PSA would come down for a notable period of time. And once the cancer got loose, my PSA doubling time was about 6 weeks. So as a result of that, I elected to do a PSA test every 6 weeks. Well, recently, the last 4 PSA tests on a 6 weeks basis were all 0.1. The last one I had now last week was 0.2, which is doubling, and just, oops, here we go again. I think we have to wait until probably the next one to see if it in fact does continue to double, but just kind of hit me. Uh-oh, here we go again.
Mm-hmm. Who would like to comment on that? Some of you guys that are wrestling with recurrent disease, maybe Len or Peter. What are your thoughts for Les?
I know the syndrome well, and Les and I have talked because we both have metastatic lymph nodes. He's had some surgery on him. I've done mine with radiation. They're back again, and yeah, systemic disease, that's the game. I mean, I've had 2 PSMA scans to try to get it when it's small, but it's I don't know, it's the territory. I mean, I feel for you, Les. It's kind of crazy making, but we just have to kind of stay on top of it. You've done PSMA scans, right, Les?
I've only had the C11 choline PET scan.
You might want to talk to Dr. Kwan and see if you'd be a candidate to get into a trial for a PSMA scan. You might, I mean, there might be some around the Midwest someplace that you can jump in on, because it might give you something a little more accurate.
He had talked about having starting doing this Axiom scan. I don't know if they've gotten to it yet. I don't know if that.
Axiom is not very good if you're at the 0.2 level. I'd lean on him and see if he has any connections with PSMA trials that might be appropriate.
Okay, I'll check
Peter,
on it.
Even at 0.2, PSMA is not that great, is it?
Well, by the time you line up the test and everything, it's probably going to be about 0.8 anyway.
Yes, that was my calculation that doing the C11 choline PET scan, they said their lead time is 2.5 to 3 months. So in that period, I would be up to the, around 1 plus probably.
Len?
That's it. I don't.
Oxygen scan. Oxygen's not the greatest, but Len can probably tell you more about that.
Yeah, well, my opinion is similar to Peter's. I mean, this is the name of the game that we're in. I don't want to be a Debbie Downer, but if we're Gleason 9s or we're Gleason 10s, barring some miraculous events or developments in treatment, this disease will eventually take us out. And so I don't, if I see a PSA rise, I just say, well, I'm grateful for having made it this far. And here we go again, as Les said. And so you just get together with your oncologist and say, okay, let's start a new plan. But recurrences are going to be in our future. There's just no doubt about it.
Yes, I understand. I was just hoping for a little bit longer.
Yeah, we all hope for that. Nothing wrong with hoping. That's fine. But don't let it crush your spirit, because this is the reality.
Right. Okay. I don't want to take up any more time.
Well, there is one thing I would like to ask the guys for you, Les, which is that, Les, you've been on intermittent hormone therapy and you've been on a holiday since when? When did you stop your LHRH?
My last shot, the Lupron, was 1 year ago, and it was a 4-month shot. So I've essentially been off for 8 months.
Okay. What thoughts do you have on when, if it were you, when would you, Len or Peter, when would you be resuming your your Lupron, your LHRH?
Not until I was scanned. I'd wait for the PSA to get high enough for a sensitive enough scan to pick up where the new lesions are.
And if you're going to get into a PSMA trial, you almost have to wait until you get in the trial, because they won't take you if you start on drugs.
Yeah, you could always start the procedure to get into a trial. And if you're fortunate enough for the PSA not to rise sufficiently, then you just tell them, I'd like to delay the scanning.
And you start taking Zytiga or whatever else the day after.
Well, as you did, Lynn, you might also do genomic sequencing if you can get a piece of the cancer to find out whether or not that stuff is mutated. I mean, I know you just did that. You don't think that's possible?
Who was that for, Ken?
That was for Lynn.
Oh, sorry.
No, I would say, if you're, a Gleason 9 or 10, and your PSA starts to rise, once you get your scans in place, as Lynn mentioned, which you really need to do. I mean, you're lucky. I want to say lucky. You're on a holiday at the moment, which I haven't been able to take myself. But if you're on a holiday and your PSA is going up and you get your scans and you find some bone mets that you can actually get into and get a piece of material out of and have it sequenced and find out whether or not your cancer is mutated, then maybe you'd have something to work with. Bottom line is you probably are going to have to go back on at some point when your number gets high enough. You'll have to go back on some kind of a drug to, either one of the drugs, Lupron, Firmagon, Abiraterone. But I know Lynn did it, and I'm probably gonna have to do it myself. So, I mean, it's a tough thing to get around. But go ahead, Lynn.
Yeah, I was just going to say, I agree 100% with you, Ken. That's exactly what I did. I waited for the PSA to get high enough so that it could be detected in a more sensitive scan, and then I had a biopsy done of the lesion. In this particular go-round of biopsies, nothing actionable turned up, but it might have been something actionable, and then we would know what the next treatment would be. But Anyway, yeah,
It
I know
was
you got to move on, Rick.
So where was the lesion, Len? It's David Muslin speaking. Where was your lesion?
Mine, well, I had 3 bone lesions, one in the right hip, the superior iliac bone, and then I had what was it, one of the ribs, the bottom rib, what they call the free floating rib. I forget what number it is, 11, 12, I don't know.
Yeah.
Those are the 2 that lit up the most. There were, they said there was some bilateral pubic bone uptake, but they weren't sure if they were stress fractures or real lesions. So anyway, I just went back on ADT, not just, but in September, and just going to ride that out for a while and then get rescanned.
Yeah, anyway, Les, there are options, Les. I mean, you have things you can do as it progresses to kind of beat it down or find a path. So don't get too discouraged.
I would just like to leave Les with one comment, which is that this might be, Les, also a very good time to set up a second opinion with a more conventional GU medical oncologist. I know you have a lot of faith in Quan, but I do feel that the treatment he offers later stage is kind of limited, and it might be very helpful right now to think about at least getting a second opinion so you can decide who you want to be your quarterback over this next phase.
Yeah, I hear you. It's just that, as I mentioned before, when I was first diagnosed, I was told that I had less than 2 years to live, and Dr. Kwan's been stretching it out to over 7 now. And man, it's hard to leave something that's doing the job.
Well, I'm just saying to get a second opinion so that when you go in to see
I did go to see Luke Nordquist. That's been, 2 years ago, I guess.
Right. Well, I mean, Nordquist is a good option, or, one of the docs at Northwestern is a good option for you, or Chuck Ryan in Minneapolis. But I think I would want that ammunition in my belt for when I talk to Quan. And one of these issues, and one of the specific issues really is the PSMA scan, because he does not seem to be such a firm believer in that. But I would just encourage you. It might be a good time to get a second opinion at this point to give you some ideas.
Okay, thank you, Rick.
Yeah, let me just add that you've been what's been shared with you is that we're all just hopping rocks. We hop to a rock, we ride it as long as we can. When the water comes up, we look for the next rock to hop on. You've got many options and alternatives down the road. And I've been saying, here we go again for 21 years now. So, and I'm still saying it. You get frustrated. You just learn to fall down 5 times and get up 6. And so just get up that 6th time, man, and just keep looking for the next rock to hop off on.
Will do. Thank you.
With that rock hopping, we'll go to Carl, and we'll give you as long as you need, Carl.
Well, come on, I don't want to keep people too late here. It's 9:53 Eastern time. But to continue the discussion thread about scans, and I have to somewhat apologize whether I had asked about this before, but I don't remember specifically. I did ask before. I got some answers about my need for an updated scan. It's been a little over a year. My PSA has been undetectable as a result of being on olaparib, the PARP inhibitor, and I got a script from my oncologist for an updated Aximum PET scan because I had one a year ago. And when I contacted the radiologist's office to make the appointment for the scan, and I made a point to say to them, well, you know, I'm not really sure whether the Aximum should be the best one for me considering my PSA is undetectable. And they said, well, you might be right, and we'll have the radiologist give you a call back on Monday, which is today. He did not call back. I have a feeling they closed the location because here in New Jersey, everything seems to be shutting down all over the place, including the fact that I was scheduled for a colonoscopy in 2 days, but that was also deferred to a later date because it's an elective kind of procedure, obviously. So ultimately, my question is, what should I be having as far as an updated scan? Now, again, it's really to check how am I doing. PSA is great, but you know there's some aches and pains, and I just want to make sure. And as was discussed in my previous question about whether to have a scan, and I know Ken had given some good information, and Len as well, that you know sometimes it's every 6 months, every year, every 18 months. So I figured, okay, hey, I need an updated scan.
If you're undetectable, those kind of scans are not going to do anything for you. It's a waste of money. I would just do a CT scan or something, or standard scan maybe. But Oxygen or PSMA scans aren't going to do anything if you have undetectable PSA.
Well, even to use it as a comparison from a year ago's scan?
No, you're not going to get any good information out of it.
What was your PSA a year ago, Carl?
Let's see. I have to recall before I went on to the olaparib, I was ending with Zytiga, and I was at 0.55.
Well, the problem, I think, is that you might have gotten a result from the Axumin at 0.55, but you're probably not going to get a result at 0.1. And so that's really the issue. It's the nature of the technology. And whilst it's good to compare apples to apples, it might be a good time just to get a regular bone scan, CT scan, so at least you have that as a baseline. Who else, Len? Do you have a comment on this? You are our scan expert here.
Yeah, no scan is stating that it can pick up a lesion lower than 0.2, and that includes the most sensitive PYL scan. So, Carl, just because a certain amount of time has gone by, I don't see the need for another scan. Just be grateful that you're undetectable and keep riding that wave. And whenever the PSA, if ever the PSA rises again, then start considering a scan. I agree with Peter and Rick. I just don't see the point of doing a scan right now.
One point, though, that with a higher Gleason score, there's the possibility of cancer expanding without giving a PSA rise.
And there you go. My Gleason score was a 10. Where is a 10?
Yeah. Yeah, I mean, and that's a really good point, Les. That's why, for me, I think I might go to something like just a regular CT scan and bone scan with whatever the common or garden contrast is. What's the common or garden contrast that they use for for a CT and a bone scan, Len?
Gadolinium. The contrast agent?
What is it that they're injecting into you so that they can see the
Technetium 99M, it's called.
Okay.
It has a structure similar to calcium, so it gets picked up into the bone just like calcium would, if it's an actively metabolic area, which you would have with a bone lesion. Technetium 99.
Well, also the technology, the equipment itself. This doctor here in New Jersey has one of only 5 GE latest and greatest PET scanners in the country. It's a digital GE PET scanner, which he had said he has one of only 5 in the country, and one of them is at Harvard University. So, to the extent that this is a very expensive piece of equipment, for lack of a better word, whether that makes a difference or not.
Well, Carl, all I can say is if you really think you'll get any value out of it, have one.
Well, just hold on a second, Ken. Let's just stick on this agent issue. So what sort of agent would they use for this PET scan? I mean, they have to put something, into you for the PET scan to be able to spot it.
Right, so, and I had 3 previous scans. I did have a bone scan. I had an F18 scan and the axonal. Those are the 3 that to compare against.
Okay, and what do they, Len? What do they use for these PET scans?
Well, there's, as Carl said, there's the sodium fluoride PET scan. There's the Axumin PET scan.
Mm-hmm.
And you have the PSMA scans, the gallium and the PYL.
The only concern would be the frequency. So I think your point, Rick, is when was the last one done? And, if you're getting them done every 4 to 6 months, it's probably not a good idea. But if you're 12 to 18 months out, then probably not a big issue.
Ken, with respect, it's not an issue of frequency here. It's a couple of other issues. One is you've got to be, what is it we're comparing to? So, we want to compare to the same thing. So in Carl's case, it was Axumin to Axumin a year apart, except that his PSA is much lower now than it was when he did the last Axumin. And Les raises a very good point that, well, with high Gleason, it's possible that they don't make much PSA anyway, and there could be lesions there. Other alternatives to the Axumin could be, with this very fancy PET scanner, could be, I guess, with sodium fluoride, right, Len? Or
I don't know what they use with that PET scan that he's talking about. I'm not familiar with it.
Yeah, well, all my PET scans were with that same piece of equipment.
So you had an Axumin with that equipment, and you had a sodium
F18.
fluoride with that equipment?
Yes.
Well, F18 is not sodium fluoride, right?
Yeah, no, it is. No, that's it. It is? Sodium fluoride F18, yeah. That's yeah.
Okay. So maybe getting another F18 might work, and possibly the problem with the regular Axumin is that we know it doesn't show. It usually doesn't show, but in your case it might. I don't know.
Right, and I'm deferring to the radiologist. I'm deferring to the radiologist, waiting to hear back from him. So,
I think
regarding what Les said about, well, maybe it's I guess neuroendocrine or small cell. So there are other markers that they could use to see if something like that is going on. As Jerry mentioned earlier, they have the chromogranin A test for neuroendocrine cancer, and there's a couple of other markers for that don't come to mind right now. But there are other ways to discover if you have neuroendocrine.
Yeah, and I would say that in Carl's case, where he's on a PARP inhibitor and responding, and on Lupron and responding, It doesn't sound like neuroendocrine disease or small cell-like disease at this point.
I agree.
Not that it couldn't be, but it doesn't sound like it. You know, thank goodness.
Yeah, yeah.
But I think you're doing I think the right thing is to speak to the radiation oncologist. He understands. He knows what can be seen from an Axumin scan. He does them, and what can be done. And ask him, you know, what's most likely to show where I'm at. I don't. It's not a bad idea to have a scan a year apart. The question in your case is what type of scan.
Right.
I think I hate to say it, I feel we're confusing you more than helping you tonight.
No, that's never the case with this this forum.
I mean, it's a great question to ask the radiologist. Why should I get a scan when I have undetectable PSA? And what will he say? I'd be interested to know.
Well, the why is because I want it.
Oh, you want it?
Yes, yes.
Yeah.
But I want the right one.
It may not be a right one.
Right.
The right one may be no scan.
Yeah, yeah. Okay, I will keep you apprised.
Okay. Anybody else have any final input for Carl?
I just want to repeat what Len said. Ride the wave. Enjoy the moment.
We like that.
Don't go looking for trouble.
All right, guys. Well, look, we're doing not too bad. We're only 5 minutes over, and we had a big group. So we lost a couple of people along the way, Larry Fish and somebody else. I'm not sure who, but by and large, we're doing okay. So please think about joining us on Thursday night. I don't know what Rich Jackson has up his sleeve, but he usually has something other than his arm, and he is a terrific moderator, as Jerry will attest. And I'm hoping Jerry will join us too, because he's really an expert in this field of speaking freely, or as Jerry calls it sometimes, the wilderness walk. And we will be back next Tuesday, and you'll see an email coming from us during the week. It's going to go out to everybody, so don't delete it. Read what's going to be in there, and keep the faith. We'll talk to you next week. Okay. Good night, everyone.
Good night, everyone. Thank you.
Good night, everyone.
Appreciate it. Talk soon.